Okay. Okay, good evening, colleagues. It's a pleasure once more to welcome all of you to our weekly webinars. And it's a great pleasure to have one of the elders in our medical fraternity to be doing a presentation to us this evening. Just as a reminder, this is a webinar hosted by Clinics Health Group, and my name is Raymond Bill. I'm the Group Medical Officer working for Clinics Health Group. And this evening's webinar is also streamed live on YouTube. It's a great improvement from where we started. This is with the idea that if you missed this webinar or for some reason you want to go back and listen to the presentations, you can do so at your own leisure. There is a link that will be provided for. Perhaps you can put the link on the chat group, Kamo, so that anybody who wants to go back and watch the webinar on YouTube, they can do so. Just as a reminder that these webinars are CPD accredited, and we thank the HPCSA that now that the attendance is automated, meaning that once you provide your full details, your MP number and your email address, the webinars will be uploaded in conjunction with Summer that we're working with to make sure that your CPD points are uploaded almost immediately at the end of the presentation. So you don't have to call us for CPD points. But those who have submitted their email addresses and are still having some outstanding CPD certificates, please do not hesitate to contact us. There have been a few in the past who have done so. So we can then send you your CPD certificates that you can then upload them on the HPCSA website. The email address to send this conversation or this request is webinars@clinics.co.za. And so this evening, we continue once more with our webinars, and we hope that we'll have an engaging session at the end of the presentation. We have Professor Yosuf or Joseph Veriava, as is popularly known, who's the Emeritus Professor at Wits University, the Department of Internal Medicine, Faculty of Health Sciences, and also is a certified nephrologist and a specialist physician. He's someone who's well known to most of us in the medical fraternity, that he qualified as a doctor at the University of the Witwatersrand in 1968. Most of you perhaps were not yet born. And he did his internship at the then Coronation Hospital, now the Rahima Musa Hospital, mother and child. Worked at Chris Barin as a medical officer in pediatrics, and then also completed a postgraduate study in internal medicine. I mean, he qualified as a physician. Worked at Coronation at the same time. And when J.G. Stradom and Coronation amalgamated, he continued as a specialist physician at the hospital. He was later appointed as chief specialist at St. Joseph Hospital, an academic head of internal medicine in 2005. And he's occupied a number of positions until retirement, but I think what is also well known of is that he's one of those doctors who challenged the then medical council, medical council, the current HPCSA, on the death of Steve Biko, and instituted a hearing that proved that Steve Biko was actually killed by negligence from the doctors who were looking after him. I want to go through a number of positions that he holds, and is currently assisting us with the risk management of cases at Clinics Health Group, a member of our risk committee. And it is a pleasure this evening to welcome Professor Veriava, who will be speaking to us on hypertensive emergencies. So, Prof, we welcome you once more, and we know that this won't be the last time we invite you to come and speak to us. As we talk on a number of occasions, we'll always engage and discuss cases that or presentations from time to time that are of interest to the medical fraternity. We know that on ethics also would love you to come and discuss cases on ethics. And so today it's just pure hypertensive emergencies. Thank you and welcome. We also request that anyone who's logged in, please make sure that you mute yourselves and you switch off your video to manage data connection and also clarity of the presentations and audio sound. Thanks a lot and welcome, Professor Veriava.
Thank you very much, Dr. Bila. And also thank you for the opportunity to make this presentation this evening. And also the various colleagues that have come along. I hope that they enjoy this presentation. And I'm going to try to be as clinical as possible. Now, in relation to my opening remarks, sorry, this thing is not moving. Sorry.
Prof, Kamu will help you. Kamu, if you can help Prof with the, just check what's happening.
Hi, Prof. Please click in the on the middle of your presentation. Click on the slide.
On the slide.
Yes, and then try and move it down.
Sure,
Okay.
great.
Okay, right. Okay. Now, I'll start off by saying that hypertensive emergencies are by no means very common. And most hypertensive emergencies are associated with severe or stage 3 hypertension. According to the South African hypertension guidelines, stage 3 hypertension is associated with a systolic blood pressure greater or equal to 180 millimeters of mercury, or diastolic blood pressure greater or equal to 110 millimeters of mercury. It is, however, of concern that patients who present with severe hypertension are, in many instances, subject to inappropriate physician habits. This was illustrated by Rahman et al. In the American Journal of Hypertension. These individuals conducted a 3-month survey at 3 hospitals. Now, 3.4% of patients were given sublingual nifedipine. 63% of were given orders were given telephonically for symptomatic blood pressure elevations. Of importance was that 98% had no bedside evaluations. This also occurs in our own hospitals, whether it be at the level of the emergency department or the wards themselves. Such practice also raised concern about the relationship to potential for complications. Now, this slide shows what happens when patients that have severe or stage 3 hypertension and their blood pressures are decrease very rapidly, particularly if they use nifedipine or Adalat, and that is whether it's given sublingually or in fact orally, they fall in blood pressure is often associated with stroke. And they were in this series, I think there were 1, 2, 3, 4, 5 strokes and 1 patient who had some rare retinal injuries. So this acute blood pressure fall can in fact be significantly hazardous. And I think this is due to the fact that one needs to commence when one sees a patient with stage 3 hypertension that it is well evaluated, and not just to order nifedipine or any other drugs to drop blood pressure. And the reason this happens, and we have to get to the cerebral autoregulation. Now, if you look at this diagram, we notice that between the mean arterial pressure of 60 and 120, there is a constant cerebral blood flow. And this cerebral blood flow is around 70 ml per 100 grams per minute of brain tissue. Now, if the blood pressure falls or the below the mean or the mean systolic mean arterial pressure below 60, the cerebral blood flow will decrease. And this cerebral decrease in cerebral blood flow will result in ischemia in the cerebral parts of the brain or in the cerebral tissue. The other side of the coin, where you, with autoregulation failure, where the blood pressure goes quite high, above about mean arterial pressure of greater than 120, we have cerebral hyperperfusion. And this cerebral hyperperfusion is associated also with some serious complications, particularly cerebral edema and also other syndromes, one of which we will be coming to later. So stage 3 hypertension has a number of types of syndromes. First of all, stage 3 hypertension may be asymptomatic. Although it's severe hypertension, it's asymptomatic. So that is the, one of the elements that may occur. Then we have what is called hypertensive urgency, and finally, hypertensive emergency. And I'll give you the definitions as we go along. When the blood pressure goes up, there's a critical degree of hypertension that in fact brings into action various effects. There are the local effects as well as the systemic effects. The local effects consist of, for instance, here, prostaglandins and free radicals. There's endothelial damage, there's platelet deposition and aggregation. Then there's mitogenic factors and migration factors and myointimal proliferation, causing a further rise in blood pressure and vascular damage, and then tissue ischemia. The systemic sort of factors are renal angiotensin system, catecholamines, and other vasopressors, and then these push up the blood pressure. There's pressure natriuresis. This gives rise to hypovolemia because of the pressure natriuresis. And then there's further increase in vasopressors and ultimately further rise in blood pressure and vascular damage with further tissue area. So there is a constant aggravation occurring in relation to damaging the arterioles. Now, the risk factors for this vascular damage is, these are the vascular damage and subsequent organ damage is related to, one, the severity of the blood pressure in chronic hypertension. So just basically very high blood pressures. And as I mentioned earlier, that it in fact overcomes the perfusion or the autoregulating capacity of the brain. Then there are acute elevations of blood pressure in previously normotensive individuals. And a good example of this is acute glomerulonephritis. Eclampsia is the other. So here you have acute elevations in the blood pressure, and this, the vessels are not protected by certain changes that occur with time, and therefore they are in fact susceptible to damage. And then the rate of change in blood pressure, the greater the rate of change, the greater the likelihood of damage to the blood vessels. And this is an example of what happens to an arteriole or an artery with significantly elevated blood pressure. These are, and if you're looking at this diagram here, these are little microaneurysms. And these occur also quite commonly in hypertensives during with the penetrating branches of the middle cerebral artery. And these microaneurysms can rupture, giving rise to cerebral hemorrhage. So going on to the end organ complications of acute hypertensive vasculopathy. Now, if the aorta is damaged, the complication is usually an aortic dissection.
You are muted, Prof. You are muted.
Am I muted?
Yeah,
No?
you just muted yourself. Now you're fine.
Okay, no, there's something else came across onto the screen.
Okay, so.
With my voice. Probably something didn't like my voice. So there's malignant hypertension. The brain itself, there are three sort of type of complications: the hypertensive encephalopathy, cerebral infarction, cerebral hemorrhage. Then the heart itself, myocardial ischemia, acute left ventricular failure, and pulmonary edema. The kidney, vasculopathy of the renal vessels gives rise to renal insufficiency, and the placenta will give rise to eclampsia. So any damage to placental vessels would in fact result in eclampsia. Now, so what is hypertensive emergency? What does it mean? It is an elevation of the blood pressure, which is associated with acute and ongoing organ damage to the kidneys, the brain, the heart, the eyes, or vascular system. It is often immediately life-threatening. It requires rapid, and I will emphasize that, it requires rapid, within minutes to a few hours, lowering of the blood pressure to safe levels. And the treatment essentially is hospitalization. And in the past, we used to say in an intensive care unit, but these days, I don't think that we can we don't have space in intensive care units, but maybe we should probably, if we can get them in the unit, that's where they should. But the key issue is that we should be able to monitor them at short intervals. And the other aspect to treatment is that the availability of intravenous antihypertensive therapeutic agents. The oral agents usually are not ideal for any hypertensive emergency. Now, the 93% of patients who present with a hypertensive emergency are chronic hypertensives. But hypertensive emergencies in the other 7% may be individuals who develop acute hypertension, whether it is associated with acute glomerulonephritis or eclampsia or any of the other causes of acute hypertension. But 93% of patients who present with hypertensive emergency are chronic hypertensives. Hypertensive urgency is not as serious as hypertensive emergency. It is symptomatic, usually with headache, shortness of breath, and edema. There's no immediate life-threatening neurological, renal, or eye or cardiac complications. And the treatment here is in hospital, and basically we commence treatment with 2 oral agents, and we lower blood pressure, lower the diastolic blood pressure to 100 millimeters of mercury slowly over 48 to 72 hours. Now this slide, various hypertensive emergencies. At the top here is malignant hypertension, is hypertensive encephalopathy, acute ischemic stroke, where the systolic blood pressure is greater than 220, acute hemorrhagic stroke, systolic blood pressure is greater than 180, acute coronary event, acute cardiogenic pulmonary edema, we got acute aortic dissection. And below that, I also had pregnancy-induced hypertension or eclampsia. And looking along this line, this column here, which is timeline and target, we notice that malignant hypertension, the timeline is to try to bring down the blood pressure, is several hours. And the mean arterial pressure should go down by about 20% or 25%. And then on this side here, the first line treatment is labetalol, also nicardipine. Now, labetalol is an alpha beta blocker and it can be given venously. So, and I think I'll say a few words about malignant hypertension. Now, malignant hypertension is diagnosed by the finding of papilledema, where there is quite, the disc is all red and not well defined. But recently, not recently, it was probably a couple of years ago, that the workers in Scotland found that fresh hemorrhages occurring in the retina are also indicative of malignant hypertension. And the reason they decided that freshly developed hemorrhages like papilledema should also be regarded as malignant hypertension is because the prognosis with freshly developed hemorrhages is the same as that due to papilledema. The other finding of soft exudates does also indicate malignant hypertension. So malignant hypertension we can diagnose by looking into the fundus and finding papilledema, this soft exudates, retinal hemorrhages, these are new retinal hemorrhages. And pathologically, this is how malignant hypertension was initially described, consisted of fibrinoid necrosis of glomerular arterioles and fibrous endarthritis of the interlobular arteries of the kidney. So that's malignant hypertension. And untreated malignant hypertension occurs in various clinical subsets. The untreated hypertension can progress to malignant hypertension in 10 to 20 years, usually in older males, 55 to 65 years of age. And the morbid events that occur are stroke and heart failure in this clinical subset. Malignant hypertension also can develop de novo over 2 to 5 years, mainly in males aged around 40 years. And morbid events are mainly renal insufficiency, hemorrhagic stroke, and heart failure. The fulminant form of de novo malignant hypertension, usually young females around an average age of 37 years, and they present with acute reversible renal failure. Now, the most common morbid events associated with malignant hypertension was malignant hypertensive nephropathy. Now, and there were two studies that I quote. The first one was the chronic hemodialysis patients at Chris Hani Baragwanath Hospital, and this was published by Gold whilst he was head of nephrology at Chris Hani Baragwanath, and 49% of these chronic hemodialysis patients were due to malignant hypertension. Another study that I did was in the South African Dialysis and Transplant Registry, and this was over a couple of years, and the malignant hypertension as a cause of end-stage renal failure were 37.4% at that stage. So malignant hypertension was a major cause of nephropathy requiring dialysis in patients. And that was malignant hypertension. And the timeline is to bring down the blood sugar several hours, and you have to down by the mean arterial pressures by 20 to 25%, and labetalol is the ideal drug. The next condition is hypertensive encephalopathy. And here in this condition, you need to bring down the blood pressure immediately. And the mean arterial pressure should go down by about 20 to 25%. And again, we talk of labetalol and nicardipine. Now, hypertensive encephalopathy usually, from a clinical side, has an acute onset of lethargy, confusion, visual disturbances, headache, seizures, and coma. And it could be fate. And the pathology itself is that of cerebral edema and microhemorrhages. And it can be diagnosed by scan besides the clinical side, where there is a posterior encephalopathy on an MRI. The next sort of condition that I'd like to go on to is an acute ischemic stroke, that is with systolic blood pressure greater than 220 and a diastolic greater than 120. And these with stroke, and I'll mention something further, that the timeline and target BP is 1 hour to bring down the pressure, but, and this needs further discussion. And the mean arterial pressure should be brought only by about 15% down. Again, labetalol and nicardipine. And this is just an example of cutoff here, the middle cerebral artery, where there is no perfusion occurring. And the actual management of acute stroke, first of all, we do not like to lower the blood pressure in acute stroke. Now, in the past, we said don't lower it at all or use antihypertensive medication unless the blood pressure is a systolic blood pressure of greater than 220 millimeters or diastolic blood pressure of 120 meters, because the rapid fall may aggravate cerebral ischemia and worsen the stroke. Now, if the blood pressure is above these levels, then treatment should aim not to lower the blood pressure by more than 15 to 20% in the first 24 hours. This shows what happens with the stroke. Now, this is the infarct core, the core infarct, where the cerebral blood flow is less than 10 ml per 100 grams of brain tissue. And the cell membranes are disturbed, and this is irreversible. The next area in the infarct is the ischemic penumbra, and here the cerebral blood flow is about 20 ml per 100. So there is some additional blood flow here, and the cell membranes are intact, and this is reversible, provided that the ischemia is in fact not allowed to continue. And this is just the normal brain tissue, where the cerebral blood flow is greater than 20 ml per 100 gram of normal brain tissue, and this is normal brain. So the big about treatment is to try to preserve this ischemic penumbra. Now, when patients develop a stroke, and if they do get to hospital within 4 or 5 hours, one prefers giving them thrombolytic or to give them thrombolytic therapy. Now, giving thrombolytic therapy, there is again the danger of bleeding, but maintain and the recommendation is that in such instances, one should maintain the systolic blood pressure below 180 millimeters of mercury and the diastolic blood pressure below 105 millimeters of mercury with with intravenous antihypertensive therapy. The next sort of hypertensive is the primary intracerebral hemorrhage, and the treatment should be started if blood pressures are greater than 180 over 105 millimeters of mercury. And the reason, and you notice here, that it often starts off here on the left with a small amount of blood, and this carries on increasing until there's massive amount of blood, which will also increase the intracerebral pressures. So acute ischemic stroke, the timeline is usually 1 hour, and we can bring down the blood pressure, unlike in the past, and we would like to bring the mean arterial pressure down by 15%. And again, the same drugs, labetalol and nicardipine. The acute hemorrhagic stroke and systolic blood pressure greater is again 1 hour. And just as we treat acute ischemic, the target blood pressure is the same as that of an acute ischemic stroke, and the drugs that are used are labetalol or nicardipine. The next sort of hypertensive emergency is an acute coronary event. And here the timeline is immediate to bring down the blood pressure. But the systolic blood pressure should be brought down to less than 140 millimeters of mercury. And the drug, first of all, the drug of choice is nitroglycerin, which has an impact on the coronary vessels as well as the blood pressure. But labetalol and nicardipine are also useful in this regard. Acute cardiogenic pulmonary edema, also again, immediately the blood pressure should be brought down, and the systolic blood pressure should be brought down to less than 140 millimeters of mercury. Again, nitroglycerin. But here, because of the pulmonary edema, this would require a diuretic. Acute aortic dissection is a very serious sort of problem, and the blood pressure must be brought down immediately. And the blood pressure targets, I've had it here, but the screen doesn't allow it to be shown, but it's the systolic should be down to 120 millimeters and diastolic down to 60 millimeters, and the drug is labetalol. I also had a bit on what do you call it, eclampsia, but that I think will be a separate talk we'll give in at a certain time, because that in itself is a major antihypertensive emergency. Now, just some rules in terms of treatment of hypertensive emergencies. First of all, I start off by saying admit into intensive care unit. Well, we can't do that at all. And we have to either admit them into a ward where they can be monitored closely, or if there is, unit, that's where they should be. Close monitoring of blood pressure and also automated blood pressure monitors may be necessary or worthwhile. Parenteral blood pressure lowering therapy. You can't do this giving oral tablets. Lower blood pressure, generally, as a general rule, if you don't know what the targets are, if you go down by 20 to 30% within 30 to 120 minutes in time limit, that would be reasonable. And the aim is to achieve a blood pressure of 160 over 100 millimeters within 2 to 6 hours. 100 millimeters of mercury systolic for aortic dissection. Because with aortic dissection, we need to really go down to effective low levels. Now, the ideal agent is basically one that can be, given as a continuous intravenous infusion. That's right. It has to have a rapid onset of action and also short duration of action. The duration of action is prolonged. It may, in fact, result in further complications because of ongoing fall in blood pressure that occurs because of the length of the action of the antihypertensive medication. It should be well tolerated with minimal side effects, and its effects should be predictable. These are just some other drugs. We mentioned glyceraltrinate. The sodium nitroprusside, we used it many years ago, but at the present moment, I don't think many people are using it. And then labetalol seems to be the preferred antihypertensive agent in lowering blood pressure during a hypertensive emergency. And nicardipine also. I tried to find out if we have those in South Africa. We don't, but I've been mentioning here, hoping that it will come along sometime, because it drops the blood pressure slowly, and in fact, it's well tolerated. So there's nicardipine. I don't think we use any of these others. The oral, now when do you use oral agent? And this sometimes happens when at clinics where there isn't a hospital, and there one has to transfer the patient to a hospital. In that instance, one may use nifedipine long agent. But I would prefer a single dose of captopril and then transfer the patient to a hospital. The diuretics are not for all patients. Diuretics are indicated only if there are signals of circulatory overload. And we mentioned that in the instance of cardiogenic failure with pulmonary edema. So I'd like to conclude this talk with the following remarks. With severe elevations of blood pressure, an accurate initial workup is essential for identification of acute and progressive target organ damage. The practice of responding to a telephone call from a nurse to say that the blood pressure is 200 over 120, and you say, give Adalat, is no longer acceptable. Treatment should be started immediately with parenteral or oral drugs, depending upon the initial evaluation. Blood pressure should be rapidly reduced, but precipitous falls should be avoided. reduction rather than normalization of blood pressure should be the initial goal of treatment. And appropriate monitoring, long-term treatment of hypertension will prevent the development of a hypertensive emergency. There was one slide that I lost, I don't know what happened to it, which was the problem of asymptomatic stage 3 hypertension. And all I can mention is that such a patient is, in fact, can be treated, doesn't have much in terms of target organ damage, is totally asymptomatic, is not a hypertensive emergency or hypertensive urgency. And the recommendation is that the person should be allowed to rest in your clinic or rooms for a period of an hour, and then repeat blood pressure is done. And if the blood pressure remains at stage 3 level, then the person should be started off on antihypertensive medication using 2 antihypertensive agents. And the follow-up should be within the next few days. Thank you.
Thank you very much, Prof. Veriava, for this presentation. Just to give us an update on management of hypertensive emergencies. And I like the idea that you've taken us to various categories of how these cases may present, and that the main purpose is to prevent target organ damage. And you've also emphasized the fact that we should move away from trying to reduce the blood pressure drastically, and the usage of Adalat is quite discouraged. And has that message from what you know been a message that has gone across to all clinicians, especially in the primary healthcare setting?
Thank you. I'll answer any questions if they have any, or
Yeah.
comment, or even.
There's one. The first question that I have here now. I thought you'd talk about that today. Because now in a primary healthcare setting, when the patient presents and the ICU or hospital admission is very far, what do you do? Somebody working in the rural areas.
Oh, a person who gets a hypertensive emergency
Yes.
in a rural area. Is that what you asked?
Yes, I'm asking that, yeah.
It's a very difficult problem because usually they don't have the type of agents that we have in the center. If there is a hospital around, every hospital should be able to attend to them. But if there isn't a hospital, I would in fact give them, I may give them a Captopro, 6.
Can you hear me now? I had problems, yeah. I didn't.
I may give them Captopro 6.25 or maybe 12.5 and send them over to a hospital. Or I may start off with one of the calcium antagonists, such as, the slow acting one.
So right, challenges with my speaker, it's not working. Can you hear me now?
Yeah.
Yeah, I tried to remove this headphones. Yeah, I didn't. I suppose everybody had the response to your question. Which are the 2 oral antihypertensive drugs of choice? This is the question from Dr. Dupree.
For this, for the hypertensive emergency, the ones that I've been mentioning are the two that I will prefer. But nicardipine, we don't have yet. So we would use one of the other calcium antagonists, not necessarily nifedipine.
Okay. And next question from Dr. Desai. How would you treat PET in pregnancy?
Pregnancy, calcium antagonist is not a bad idea. People still use alpha-methyl dopa, and that's fine. They also use magnesium sulfate. So there are those. But a calcium antagonist is quite a good drug to use in PET.
And
And magnesium sulfate.
Ibrahim Veriava, you know him very well. Now he's asking a question, if captopril is not available, what about enalapril and the dosage?
Yeah, one could, but I would rather use a calcium antagonist, but not nifedipine, short-acting, not that. There are a couple of other. You could use, there are quite a few. Amlodipine I wouldn't use because that takes a while before it starts working. But the others that are shorter acting.
Okay. I don't know if Dr. Veriava Ibrahim wants to say a few words. Just you ask about whether there's and he's also asked about the dosage of enalapril. So from what I think that's the same one who's in Blackstone.
Enalapril, the ideal dosage has been about 20 milligrams of enalapril. But we've been using even 10 milligrams of enalapril. One could use that. That's not a problem.
Okay. Are there any further questions? I don't see other questions. Okay. Can you unmute yourself, Dr. Veriava?
Hi, sorry.
Yeah, just and talk about your presence, maybe just to clarify that also. Sure, go ahead.
Thanks for the presentation, Joe. The issue in the state captopril is not available at all. So we do have a challenge. We have enalapril and we have amlodipine. Amlodipine is long acting, and I think a lot of people are using it. The second question is, and when ACE came about, and I think it's important for that whole issue of ACE and when you give ACE and the risk of a first dose hypotension with hyperenemic states, etc. And the issue is, I think it's important for us to know when we use an ACE with severe hypertension, when should we be worried about severe hypotension with ACE?
It's very difficult. There's no sign that and it's not everyone that has a first dose hypotensive response. They say that perindopril does not have that, but I'm not too sure. But perindopril, when it came out, was thought, that's cumbersome, was thought not to have the first dose hypotensive effect.
Okay, the question is, when you've got severe hypokalemia with accelerated hypertension, would you then be worried about using an ACE?
The hyperkalemia.
Hypokalemia with severe hypertension. Is there any risk?
Well, there isn't, because ACE inhibitors, in fact, increase the potassium level. There isn't a risk to it. The risk is when your potassium levels are high and you give them an ACE inhibitor, then you're going to have hyperkalemia. It'll aggravate the hyperkalemia. Say the person has potassium level that's close to the upper level of normal, and you give them an ACE inhibitor or any angiotensin receptor blocker, you will create dangerous hyperkalemia, or you could.
Okay, thank you.
Okay. Thanks, Dr. Dr. Malinga wants to know, what about a sudden BP swing during anesthesia? What do you do? You know, you've got a patient on the table and there's a swing in blood pressure.
Blood pressure swings during anesthesia. I must say that I have absolutely no experience there, and I wouldn't know what the mechanisms are and which drugs are responsible for that. I'm sorry, I can't help there.
Yeah. I'm not sure if there's an anesthetist amongst us here who can answer that question.
I'd appreciate it if there is someone who could answer that in the audience.
Yeah, well, if there's someone in the audience who can, as you say, Prof is a specialist physician and nephrologist, this is for the anesthetist to deal with. I'm sure they must have, unless if Dr. Malinga has had an experience of such situations. Well, if there's someone who can answer that, we'll come back to this question. And Dr. Hopper wants to know what is the hypertensive drug of choice in an HIV patient with renal impairment?
With renal involvement, I think most of the ACE inhibitors or angiotensin receptor blockers can be used because they are renoprotective. So you could use that. There's no problem about it. But then you should, in fact, just ensure that the potassium levels don't go up. So you need to monitor them closely. But the other drugs, such as amlodipine, would be quite safe. So amlodipine would be a good drug there to use if you can't monitor them regularly.
Okay. Yeah, we were hoping to have a presentation, perhaps sometime later in the year, of renal dialysis patients or kidney and renal patients also with HIV. Because I'm told that there is at some centers within our group, the number of patients who are presenting for renal dialysis actually patients with HIV. So we're hoping to have some conversation about it at a later stage when we are able to get a presentation on that. Yeah, and Dr. van der Horst just confirms that captopril is not available in the state. And thanks for that. Anybody else who's got a question for Prof. Veriava? Perhaps if you just raise your hand or unmute yourself, then we can have a conversation. But otherwise, there are quite a number of people who are quite happy with the presentation, and thanks for the wonderful talk that you've given so far, Prof. Veriava. And thanks for taking your time. Anybody else has got a question? I don't see other questions. Or Dr. Mulaudzi says, in the district hospital where there's no laboratory facility to check for potassium levels and only amlodipine, ACE inhibitors and hypotone are available, what should be the approach?
We're unable to test for electrolytes. Is that?
Yeah, I'm sure. I wonder, perhaps it's the NHLS laboratories far away from where they are.
It's a difficult thing. One could do an ECG view, but the ECG will only show the changes of hyperkalemia when it's late. But the ECG features are quite clear. It's easy to diagnose hyperkalemia on that. But otherwise, one just can't diagnose it in any other way.
Yeah, I think the dilemma is that now they have a patient Okay.
You know, there are clinics everywhere. And the clinic should be able to do those blood tests. And they should be able, or they should at least provide that service.
Yeah, well, I think it is quite concerning if there is such a district hospital that is not within reach to a laboratory. I don't know, Dr. Mlauzi, how far away is the laboratory services from a district hospital that you're referring to? You'll pardon my ignorance in terms of maybe rural hospitals that are situated hospitals are situated in rural hospitals. They can't get access to laboratory services within a certain time.
Rural hospitals in Northwest Province, starting from Zeeland, going on to Mafeking and then Lichtenburg and all that.
Yeah.
And each of these places, there were facilities for blood investigations, and even the clinics that supported these hospitals could have blood tests done. So I haven't seen a place where, but maybe I haven't been around long enough to very, very distant places where we could never get to any health center which could do certain basic tests.
Yeah, as you were saying, someone says, well, we wonder if maybe access to a BG machine, because it says Dr. Tukija says an ABG could assist to have an idea on the potassium levels. So it's one of the options to look at doing, and I think that's what you could do. If you don't have access to laboratory tests, then you can do your blood gas analysis and help you to come to a decision.
And they don't have a blood gas machine too.
Well, I think it's a matter for consideration if such a situation prevails, that those in charge of healthcare delivery and public health that should look at such a situation and see if we can't assist people like what we've just spoken about, district hospitals that have such facilities. Yeah. And Dr. Mlauzi says you only, what is it? Sorry. You send specimen only to get results the following day. That's what it says here. Okay. Professor Dr. Tutoy, renal artery stenosis induced hypertension. When, in your opinion, should a surgical intervention be done for it?
Well, if the stenosis is significant, I think one should go ahead and get it done. And if the hypertension is resistant to treatment, if they have resistant hypertension and you can't treat it with drugs, antihypertensive drug, you need to go and open up the renal artery.
Yeah, just to, yeah. I hope that Dr. Toy has been answered there. Yeah. Okay, now just someone just thanks to me for facilitation of this excellent webinars. Well, we hope to get more conversations and discussions on topics of interest to our colleagues and participants who come here. We've looked at the comments and questions and suggestions that were sent to us towards the end of last year. And we're hoping that we'll be getting speakers who will be able to talk to us about some of the pertinent issues in medical care and medicine in general. So it was great to have Professor Veriava here. And before I conclude, I think Dr. Ibrahim, and thanks, Prof. Most issues that we doctors don't even bother following up results urgently. I think it's referring to what the question that we're talking about. That also some hospitals don't have ECG and our managers don't seem to bother. We need to reappraise. Yeah, I think it's quite important. This afternoon, we at clinics wanted to intervene. Actually, we sent out a message to Professor Yosuf to say if you've got no food for patients at the hospital, because that's a message that we're getting, that there was a problem. I think when I spoke to management there, it's been going on for about 2 weeks that there's not been adequate bread delivery. And so we were ready to mobilize our 2 hospital food services units to come to the assistance of Professor Yosuf to offer food to those patients. So when we got that message, so issues like what we've been discussing about medication and not medication, but I think access to laboratory services. This brings us me to a discussion that we'll be having. Towards the end of this month, we will be having someone from the Department of Health speaking to us on NHI. So we hope that we'll get more information, because I think we're at a stage where there needs to be a convergence of healthcare delivery between the public and the private sector. And NHI is a vehicle that we'll be using. So some of the discussions, issues that have been raised here, we hope that they'll be given prominent attention later this month when we have a discussion on NHI. But I just want to take this moment to thank Prof. Veriava for this excellent talk that you've given us. And as always, you touch on areas that affect direct healthcare delivery, and hypertensive emergency is one of those conditions that if we miss the opportunity, we lose a life. And I think that everybody who's been connected to our webinar this evening is well empowered to manage a hypertensive emergency. And so we just want to thank you that in your retirement time that you still give us your time to talk to us, and we are quite honored to have you in our midst this evening. And also I just want to thank all the participants, or those who've been joining us every week. We always get good numbers, and quite a number of you are regulars and also first timers. We just want to say thank you for joining us, and please do send us proposals about what topics to talk about, who speakers who can engage us. And we've seen some of the clinicians who participated this evening. These are people that we'd also want to hear from in future webinars that we shall be organizing. And I just want to thank the Clinics Health Group leadership for making this possible, that we have these conversations every week, and to thank the marketing team also that work together with the clinical team to put together this webinars every week. This evening we've got Gamo, who's been part of this team from the beginning. We just say thank you. And thanks, colleagues, and we hope to have you back next Thursday as we'll be continuing with our talks again. Thank you very much, and have a good evening. Yeah, Dr. Hussein, we'll get ethical talks quick. Thanks.